All right. So for those here who might not know me, thanks, Nips. All right. So for those of you who might not know me here, my name is Sarah. I'm one of the fourth years, and today I'm going to be doing an EMCCM lecture. Big thanks to the CCM team who went back and forth with me about this 4 weeks. That was fun. So we are going to talk about a 25-year-old male whose chief complaint is fatigue today. So EMS brings in this gentleman. He's a 25-year-old male, they tell you, and he has a past medical history of cardiomyopathy, coming in complaining of weakness and migraines for 2 days. In the field, his vitals are within normal limits. His GCS is 15. His finger stick before arrival was 58. And EMS says their EKG was atrial fibrillation, but there's no copy of it anywhere in the chart. So before he came in, they placed a 20-gauge IV. They gave him 450 cc bolus of normal saline. He got 1 amp of D50 and glucagon 1 milligram IM. His repeat finger stick before he arrived was 129. So he's brought through CCT, and on his initial assessment, his airway's intact. His breath sounds are clear and bilateral. He has warm extremities with equal pulses throughout, and he's noted to be somnolent but following commands. Initial vital signs in the ED are also within normal limits, so heart rate 80, BP 95/57, which is a map of 70. Respiratory rate is 18, and he's afebrile, setting 100 on room air, and his finger stick in triage was 150. So he was placed on a cardiac monitor. He got 1 liter of normal saline and an EKG was done, and then he was cleared to the main ED. So in the main ED, the team there got a pretty similar story from the patient. He says that he had generalized weakness and a headache for about 2 days. And because of this, he had decreased oral intake, wasn't really able to get out of bed. Actually, it was his roommate that ended up calling EMS because they were concerned that he hasn't left the bed at all. He denied having any fever, shortness of breath, or chest pain, no nausea or vomiting, and he denied any toxic habits. Of note, in the chart as well, it says that during getting the history, the patient had waxing and waning mental status. And there was no family or the roommate at bedside to give any collateral information. So for his past medical history, he suffers from ARVD, and he has an AICD that was placed back in 2022. And he had a CVA in childhood, but did not have any residual weakness. For medications, he was on warfarin, several antihypertensive medications, Lasix and bupropion, and he does not have any known drug allergies. Does anyone want to give me any preliminary problems for this patient? Initially, but no longer anymore. But yeah, that was an initial problem. What else? Sure. Anything else? AMS as well. Yep. And then a headache, but the hypoglycemia was definitely a problem, and likely there's obviously a component of dehydration. He hasn't eaten anything in 2 days. So let's go on to the physical exam. So it was documented that he was in no acute distress and well-developed. It was written that he's moving all extremities. He's sleepy, but he's arousable if they shake his shoulder. He's opening his eyes, but does not track well, and he mumbles and answers yes or no questions. On heat exam, head is normal cephalic atraumatic. Extraocular movements are documented as intact, as well as the pupillary light reflex is intact. Cardiac exam showed normal rate and rhythm, no murmurs, rubs, or gallops. He has a sternal scar, and there's an implant noted to the right chest. Abdominal exam, normal bowel sounds, non-tender, not guarding, and no CVA tenderness. Extremities are warm and dry. And on neuro exam, he's alert, moving all extremities, no facial droop, and negative Brzezinski and Koenig signs. All right, moving on to the EKG that was done in CCT. I don't know how well you guys are able to see it, but does anybody want to try and go through this for me? Is it sinus? Yes. Okay, cool. What do you think the heart rate is? Yeah. Looks around 60. It's documented as 58. Do the intervals look okay to you guys? And I know it's kind of hard to see. Ish. Yeah. Yeah. I know the baseline is a little bit wobbly, but any T-wave inversions anywhere? Mm-hmm. Mm-hmm. Yep.
Why do you say right atrial arc? Pretty tall. Yeah.
Yeah. All right, spot on.
And some of the keywords look even bigger than PRS, right? So the better stuff going on.
Yep. So that matches up with the attending read on this EKG. The only thing they added was that there was a left anterior fascicular block. Okay. Who wants to throw out some differential diagnosis? Sure. Mm-hmm. Yep, absolutely. Mm-hmm. It's a good one too. I didn't have that written down, but that's a good one. I think that's a pretty good list. All right, so oh, that's also good.
Paraneoplastic.
So I was told to keep it relatively small with the differential. Some of these things that I did have, especially the hypothyroidism, I was told to nix, but you guys have a lot of them. So like KJ said, it could be a stroke, could be a bleed. He is on warfarin, metabolic, so hyponatremia, hypoglycemia, could be infectious, maybe they're anemic. EKG was sinus, but maybe he's been going in and out of some malignant dysarrhythmias and his AICD is failing. He denies any toxic habits, but intox is totally possible. No signs of trauma that was noted on exam, but always possible in a young guy. So several hours later, the patient's reassessed, and he's now saying that he doesn't have a headache anymore, but he's noted to be persistently lethargic. Vitals are essentially unchanged. Okay. So any tests you guys want to do? All them, sure. Okay. Yeah, okay. So the labs, the CBC comp, troponin, BBG, coags, and UA, this was sent from CCT. And then the main ED team sent off, ordered the CT head and the chest x-ray. All right. So here's the VBG. Anything abnormal to you guys that you care about, even a little bit? Yep, heard it. Lactate's a little bit high. Okay. Here's the rest of the tests. Anything here you guys care about? No. Don't we miss it? Yeah. Okay, good. So the INR is therapeutic in the setting of warfarin. It's 2.3. Nothing really significant. He does have some ketones and glucose in the urine, but no infection, and his labs are otherwise pretty unremarkable. All right. Chest x-ray. What do you say? Yeah, that's a big heart. Yeah, it's a big guy. Okay. So big heart, AICD is in place. No focal consolidation was seen. Okay.
How many delta and AICD and out tanker? The coil, right? They see the big part down below. That's the part that actually looks pretty obvious.
And there was no POCUS done. I know, which is since I know you care so much about them.
I know.
Yeah.
Someone did.
Yeah.
When so impressive, yeah, that part is big, but yet the lungs are so clear.
Yeah.
The blood pressure's low. Oh, I wrote about that.
Okay. So I tried to make this slow. I'm sorry if you hear me breathe as I recorded this, but this is the CT head. All right. Well, I apologize. All right, so the official read on the CT head showed focal hypoattenuation within the left occipital lobe with loss of gray-white differentiation. Also foci of hypoattenuation within the bilateral cerebellar hemispheres and bilateral thalamic capsular region. Okay. All right, updated problem list. Oh, now it goes. Stroke. Great. Okay. So good job, guys. So the team consulted neuro. And so this is from their notes. So no stroke code was called because the last known well was 48 hours ago. And they're documenting that this patient has an NIH stroke scale score of 6. So he got 2 points for decreased alertness and then 1 point for a drift in each of the extremities. Of note, his initial modified Rankin score was 0. So just to remind you guys what that was, because I had to remind myself, this just measures level of disability ranging from 0 to 6. 0 is no disability at baseline, and 6 is death. So make of that what you will in between there. Huh?
You have a 0?
He had a 0 at his, not his baseline. This is his baseline, not on their evaluation. Sorry, that should say baseline, not initial. All right, so neurology's impression. So head CT demonstrates bilateral thalamic ischemic strokes, left occipital stroke, which is suggestive of top of the Basilar syndrome. So they recommend continuing his anticoagulation with an INR goal of 2 to 3, which it seems like he already had. Not a candidate for TPA because his INR was greater than 1.7. Symptom onset was greater than 4.5 hours, and he had evolving ischemia on CT. They recommend getting a CTA head and neck for this patient. They wanted to repeat CT head and then a stroke workup involving an echo, A1C, lipid panel, and PT-OT eval. All right. So today we're going to talk about top of the Basilar syndrome. Have any of you guys ever heard of this or seen it? Okay. Cool. All right. I never heard of it, and I definitely never seen it. So what we're going to talk about today is we're going to define exactly what it is and briefly go over relevant anatomy. I won't slam you guys with it. We'll spend most of the time talking about the subtle clinical features and how we can actually diagnose these patients. And then we'll finish by talking about treatment options. So what is top of the Basilar syndrome? So it's a type of posterior stroke, and it's identified by a specific ischemic pattern on imaging. So you'll have ischemia of the midbrain, thalami, medial temporal lobes, and occipital lobe, which is how Dr. Law was able, just looking at this patient's CAT scan, to say that this is what they had. Cerebellar ischemia is actually not classic for top of the Basilar syndrome, but I'll show you based on the anatomy. Sometimes the superior cerebellar artery can be involved, and you can get some cerebellar symptoms in these patients. All right, so briefly, we're going to review the basilar artery. So more proximally, you have your 2 vertebral arteries that form your basilar artery. The first branch off is the anterior inferior cerebellar artery. Then as you move up along the brainstem, you get to your pontine arteries. And then more distally, you have your superior cerebellar artery. And then finally, your posterior cerebral arteries. So 20% of all strokes are posterior. 1 to 4% of those are basilar strokes. And we are going to focus today on strokes at that little circle I made right over there. All right. So a little more anatomy, not much. I don't know about you guys, but I haven't looked at this since I was in anatomy in medical school. So I just thought it was helpful to kind of understand exactly why we're seeing that particular pattern. So unlike many other LVOs, top of the Basilar syndrome is usually due to emboli, not stenosis. So it's pretty common that, get my mouse over here, that this clot right here at the top of the basilar artery is actually only transient before it breaks into smaller clots and includes 1 or both of the PCAs. And that's how you tend to get your classic ischemic findings on imaging. So here's the midbrain. Sorry. So this right here, top of the basilar artery, and I just want to show these paramedian branches that go off and supply the nuclei within the midbrain. Not going to go through all of them, but just some to point out, like right here, you have the nucleus of cranial nerve 3. And then here you have your PCAs that then go off and supply the occipital and temporal lobes. Not pictured here, but there are also paramedian branches that go up to the thalamus. Here, just to note, these are your cerebral peduncles, and ischemia of these typically not seen, top of the Basilar Syndrome. That's usually more in proximal strokes. And that's where you'll get like locked-in syndrome and pretty debilitating motor symptoms, which is not classic for this syndrome. So clinically, what does this look like? So we'll start with altered mental status, and this is due to involvement of the thalamus, and probably the most common symptom of this syndrome and can easily be missed for other things. So hypersomnolence is one of the most common presentations. Confusion and disorientation is also present. So patients oftentimes mislocate where they are in place or time, or they say that they're doing some type of activity that they haven't done since they were in childhood. Then peduncular hallucinations. So what those are, they're very vivid visual hallucinations that contain colors, objects, and scenes. Sometimes they have tactile or auditory components, but it's mostly visual, and that's due to ischemia near the cerebral peduncles in the midbrain. And then patients have an inability to form new memories, and that's due to involvement of the medial temporal lobe. All right, visual deficits. So most commonly, these patients will lose their voluntary and reflex vertical eye movements. Sometimes it's just loss of voluntary movements, and usually it involves both upward and downward gaze, but it can involve just one or the other. Also skew deviation and esotropia, which is where the eyes are looking down towards the tip of the nose. Pupillary light reflex is affected. You can get a pseudoabducens palsy where they're unable to look laterally. Collier sign, which is pathologic retraction of the upper eyelids. And before I move on to the last two, if you guys remember hearing about Parinaud syndrome back in the day, that has to do with ischemia in the midbrain. So those first 5 symptoms actually constitute Parinaud syndrome. And then contralateral vision loss you can get if just one PCA is occluded, or if both, you get cortical blindness. Okay, so again, cerebellar signs not typically common, but I think it should be mentioned because it could happen if the SCAs are involved. So vertigo is usually not a prominent syndrome. If anything, they might say they have mild dizziness. They can have nausea, vomiting. If you walk them, you might see an unsteady gait. They can have dysmetria as well as dysarthria. And of note, in our patient's review of systems, he didn't have any of these that he was endorsing. So this diagnosis is pretty hard, which is obviously why we're talking about it today. I mean, as you can see, all those things that we just mentioned, you can see them in other complaints. And if you're not thinking about stroke, you might not find it. It's pretty difficult to diagnose without a thorough neuroexam and knowing what you're looking for. And if you do have a patient that's even like lethargic or just slightly altered and you find any focal neurosign on your exam, you have to think there's a high likelihood of vascular involvement.
I think the reason this one's so hard is because it's got bilateral symptoms. They're starting in the midline and infecting both sides. Almost all strokes are unilateral. This one's got bilateral findings, making it much tougher to figure out.
Yeah. So talking about why exactly it's so hard. So that's a really good point, Dr. Silverberg. Thank you for saying that. Also just in how we think about strokes is essentially why I think it's so hard. So you guys recognize this, you might see it in triage. That's how sometimes, stroke codes are called, or how the general public is taught to recognize if a family member or a friend is having a stroke. So FAST is the very common one where you look for facial asymmetry, arm weakness, difficulty in speech, and time getting the patient to the hospital right away. Balance and eyes were added a little bit later, which helps find posterior strokes. But again, it doesn't really include anything regarding change in mentation, which is the most classic finding in any type of basilar artery stroke, not just top of the Basilar syndrome. Even when EMS calls us, this is very specific for anterior strokes than posterior strokes. So do you guys know what this is? Has anyone ever taken the call for a stroke notification in CCT, and they'll tell you what a SLAM score or LAMS score is? Yeah. So that's great if EMS calls ahead of time that a patient's having a stroke, and now it's definitely on your differential, you're thinking about it. But a lot of times if a patient is coming altered and they're bringing them in, some will say that the patient has a stroke, but it's not really captured by this tool that is typically used by FDNY.
When it's high, the rollover for also stroke already.
Mhm.
Can be in the room.
Gotcha. So if you're getting a stroke notification, but they say the slam is not high, do you wait or? Okay. No, that's good. Okay, so NIH stroke scale. Better than the other two things I just showed you. This is obviously how we all rate the severity of strokes. But again, this is also pretty heavily weighted to anterior stroke symptoms. So I didn't want to actually pull up the NIH stroke scale because you weren't going to be able to read it if I put it on the slide. So if you guys want, you can see it on MD Calc, pull it up pretty easily, but these are the main categories that it looks at. So even just looking at level of consciousness, so it's broken down into level of alertness and if they can follow simple commands or answer simple questions. If a patient's completely unresponsive, they only get 3 points. So it's not that high. Best gaze, you're really only supposed to look at horizontal gaze palsy. So if a patient only has issues with vertical gaze, they wouldn't get any points. Visual fields, ataxia, I mean, this can catch some of the posterior strokes, but you can have significant disability here and not have that high of an NIH score. And there was actually a center that tried to look at it. So this was published by a single stroke center back in 2010, and they aimed to look at all patients who had strokes that were found on MRI, who had acute persistent symptoms, but their NIH score was actually 0. So it was a retrospective study. They looked at patients between 2004 and 2008. And of the 4,000 patients during that time that were evaluated by the stroke team, only 20 met this criteria, but still 20 patients. And I think it just highlights that there are some limitations to the NIH score. So for those patients that met that criteria, most of them came in presenting with a headache, vertigo, nausea, or ataxia. The most common neurosign was truncal ataxia. And while there were some patients that had strokes in the anterior circulation, the majority had posterior circulation strokes. Again, this was only 20 patients. So, you know, I don't make of that what you will. It was really just to highlight that there is some disconnects between symptoms and NIH score. Okay. But I mean, you guys are all superstars. So I know that if someone comes in and is slightly altered, you're going to do a great neuro exam. I don't have time to go through the whole neuro exam, but I do want to highlight the ocular findings that you would suspect to see in a patient that has top of the Basilar syndrome. So this one, you shouldn't hear my breathing. All right. All right. So you can see his eyelids are retracted. No issues with lateral gaze. Unable to look up. Downward gaze is fine. And you can start to see some convergence nystagmus, which is also part of the syndrome where the eyes inward.
Right, you can see it's subtle, right? But you can see even though the patient can't look up, you can even see that they're not both looking up, right? You can see some of the skew here. So that's what we're talking about. We're talking about like vertical skew and like against exam and some of these other things looking for signs of cerebellar strokes, posterior strokes.
Okay. All right. So you send these patients for imaging, and I think most of us probably already know that CT head is not great for finding posterior strokes. It has a pretty low sensitivity in general, and it only, the sensitivity ranges from like 7 to 42%. That being said, if a patient with top of the Basilar syndrome does actually still have a clot at the top of the basilar artery, you might get this hyperdense basilar artery on your CT head, and that's seen in about 50 to 70% of patients that have that clot and also has the syndrome. So not everybody's going to have that clot still there. And then again, you can see just an example in the lower picture here where that white arrow is, you can see on CTA where you might see the loss of flow. All right. MRI is a little bit better, but still has its limitations. So this MRI is showing the classic ischemic pattern that we tend to see. So the occipital lobe on the left, medial temporal lobe in the middle, and then you can see thalamic ischemia on the right. But even an early MRI can still miss it. So about 6 to 10% of early MRIs might be negative. It becomes more sensitive as the clinical course goes along. So if a patient is persistently symptomatic, even an early negative MRI does not actually rule out a CVA. So how do we treat these patients? I know Mohammed covered a lot of the TPA stuff, but first and foremost in the ED, ABCs, right? That's what we do. Patients, not just patients who have posterior strokes, not just top of the Basilar syndrome, any stroke, there's always the risk of cerebral edema and herniation. So always frequent neuro checks and make sure their airway's okay. They could have worsening mental status that you have to intervene on. Thrombolysis, reperfusion is the goal. So if someone comes in within 4.5 hours, there's an ischemic stroke with a measurable neurodeficit and an age greater than 18, they meet inclusion criteria for TPA. But there's numerous exclusion criteria. So past medical history contraindications, I'm sure you guys know. So if they had any prior head bleed, if there was a CVA in the past 3 months, any GI or intracranial malignancy, GI bleed in the past 21 days, or any intracranial or spinal surgery in the past 3 months, they can't get it. If they're currently anticoagulated and their numbers are higher than what's on the screen there, if they have endocarditis, if they have platelets less than 100,000, if their BP is elevated greater than 185/110, if they have a bleed, obviously, and if there's already extensive regions of hypodensity seen on CT head. So endovascular thrombectomy for these patients is a little bit murky, and there's not really great guidelines on it because there's not that many studies on it for posterior circulation and even less for these basilar strokes. So most of the inclusion and exclusion criteria for thrombectomy is based on anterior circulation strokes. That being said, there's the AHA put out some recommendations in 2023 based on 2 RCTs that were done a couple years ago in China that showed functional improvement in patients that had basilar artery strokes if they got a thrombectomy. And this is not top, this is just basilar artery in general. But so based on those 2 studies, there is moderate recommendation if the patient is aged 18 to 80, if they have no real deficits at their baseline, if they have an NIH score greater than 10, which can be difficult in a patient who has a basilar artery stroke, or if their PC aspect score is greater than 8. So I don't know if you guys know what an aspect score is, but basically it's a way to measure the amount of ischemia seen on early imaging. And the PC part is it's modified for posterior circulation. So the lower the score, the more ischemia already seen on imaging. So normal is 10. And you lose a point for every ischemic lesion, right or left, that's seen in the thalamus, cerebral hemisphere, or cerebellar hemispheres, or posterior cerebellar artery territory. And then each region of the pons or midbrain affected, you lose 2 points. So you can't really have that much ischemia already if based on these criteria. Last known well should be within 24 hours. There should be a large artery atherosclerosis that can be seen. And if you do have more ischemia with an aspect score of 6 to 7, the recommendation goes from moderately recommended to maybe recommended. Other than these 2 studies, there were other RCTs that were done that didn't really show any significant benefit between TPA versus thrombectomy. And really this requires a discussion with your stroke team and any neurointerventionalists that you have at the center you work at, because if the patient's within 24 hours, because of how debilitating basilar strokes can be, some will still attempt to do a thrombectomy regardless of these recommendations. So it's worth a conversation. All right, so inpatient course. So this patient was admitted to the stroke unit. And then maybe like 2 hours later, stroke team upgraded them to the neuro ICU over concerns related to top of the Basilar syndrome, likely airway watch. During this time, there was no documented change in his mental status, but there is a nursing note that says he told the nurse that his mother brought him to the hospital to be evaluated for his superpowers. He went for his repeat CT head and CTA head and neck. All right. I'm going to slow that down because that was useless. Sorry, guys. Okay. Try that one more time. So this is the CTA. No, come right here. Does anybody see any obvious occlusion of the basilar artery here? No, there wasn't. Sorry. So the CT head repeat was it was unchanged from prior, and there was actually no large occlusion seen on this CTA. So likely he was probably like those patients that only temporary have an occlusion, then it breaks up into smaller emboli. So during his ICU stay, it's documented that he had periods of bradycardia, but no other documentation regarding that. Otherwise, his vitals were fine. He had his AICD interrogated and there were no acute events. He's documented as being lethargic and arousable only to painful stimuli. And he had a finger stick of 65, so they gave him D50, 1 amp, and this was all in the morning time. Later in the day, we get more of a detailed neurologic exam on this patient. So it says that he's sleepy but arousable. He has mild conjugate gaze with right medial relative to left. He's unable to do an up gaze on the left and overall difficulty with downward gaze. He follows one-step commands and he's moving all extremities. He also is having intermittent delusional thinking and due to his increased lethargy, so they actually started him on fluoxetine. So on the second day, he gets downgraded to the floors. And he tells the team on the floors that he's now having visual hallucinations. He's seen by PT, and this is the first time we ever get any documentation regarding his gait, and it's impaired. He had a TTE, which showed he had a reduced ejection fraction and a large RVRA. And then he was switched from warfarin to apixaban. Over the next couple of days on the floor, he had some issues with behavior. So he was wandering, he was aggressive, he was peeing on the floor, and he required Haldol several times. He got a TEE bubble study, which was negative. No thrombus was seen, and he had mild tricuspid regurg. And then he started endorsing abdominal pain, so the team sent him for a CT abdomen pelvis. It showed a renal infarct, and it's really unclear where that came from. Even the stroke, his INR was 2.3 on initial assessment, and he did have multiple compression fractures, but the fractures were old. And so they were just having him follow up outpatient regarding the renal infarcts. So he finally gets to go home on day 7. He had an NIH score of 5, but which isn't that high, but then he's now ranked as being moderately disabled based on his rank and score. So just to kind of highlight the disparity between actual disability that a patient might have and what their NIH stroke scale suggests. And he was discharged home with home PT. Okay. So in summary, top of the Basilar syndrome, you have ischemia of the thalamus, midbrain, occipital, and temporal lobes. It's a subtle presentation, altered mental status, visual deficits, and cerebellar signs. And if you are not looking for this, if it's not even on your differential that a patient could have a stroke, you are going to miss it because you need to do a really good neuro exam. And these patients really have motor deficits. So like I just said, easily missed without a thorough neuro exam. No clear benefit over thrombectomy versus TPA. So please, if it's within 24 hours, have a conversation with your stroke team about it. And then do frequent neuro checks for worsening mentation and airway monitoring. Basically, if there's one thing I want you to take away from this is if a patient comes in altered or increasingly lethargic, even if it's not your top differential, just have it somewhere on the list and do a good neuro exam. Don't just try not to do just like moving all extremities on the bed and awake if possible. Okay. And these are my references.